Thank you, Dr. Nikhil, and good morning to all of you. The topic given to me is optic neuritis. Basically, I'm going to speak to you with regards to current understanding of the optic neuritis and its perspectives in the management of optic neuritis. And most of the talk is... which one? Last one. Most of the talk is related to a demyelinating kind of an optic neuritis, because that's the most common type of optic neuritis which you will see in a clinical practice, and a little bit about multiple sclerosis, because the optic neuritis is nothing but an early presentation of a degenerative or a demyelinating problem involving the nervous system. As you all know, it's an chronic inflammatory process involving the brain, optic nerve, cerebellum, and spinal cord. Charcot was the first person who was actually put up the manifestation of the multiple sclerosis. So it affects basically the young individuals, and the age group is pretty much between 15 to 50 years, and rarely below 15 and rarely above 50, but up to 60 years sometimes it can go up to, and most commonly females are involved. And usually these are the Western Europe and the Scandinavian countries, and some parts of US, and some parts of Australia, New Zealand, and parts of India, but nobody knows actually the prevalence of the disease in India as such. Now, coming to the etiology, no definite proof has ever been put forward, though there are a lot of other theories have been said about the causation of this problem. Now, if you look at this, about greater than 1 million people are affected globally with uneven global distribution. So these are the pockets of this is in the US, the Midwest, and in the southern part of the US, and these are the European countries, and the Australia, and then the New Zealand, and then in India also we do see patients quite often. Now, coming to the optic neuritis, as you know, it's an inflammation of the optic nerve. And most commonly it's a demyelinating kind of a disease, and rarely it's associated with the infective process like syphilis or sarcoid or Lyme disease. And it can be of two types: erythrobulbar neuritis, where everything in the eye looks fine except that the vision is lost, and sudden loss of vision. And sometimes you will see papillitis. 2/3 of the patients present with the erythrobulbar type, or 1/3 do present with the swelling of the optic nerve, as was shown earlier by Nikhil. So usually it's preceded by the vision loss is preceded by the pain. Most of the times, if you take the history, there is a period of about 2 to 4 days of a painful eye movements, and suddenly the vision is lost. And that vision could be a marked vision loss, or it could be a mild to moderate vision loss, and which can progress over about a week to 2 weeks. And initially, sometimes some of these patients have contrast sensitivity abnormalities before they lose their vision. The color vision is lost, and then the visual fields are abnormal, and then the brightness sensitivity, the color desaturation. And these are some of the things which the Uthoff's phenomenon and the Hermits phenomenon, as you all know, are sometimes associated with some of the patients who have optic neuritis associated with demyelinating disease. Now, looking at the natural history, the progression in about 2 weeks' time, and then it stabilizes and then improves, usually without any treatment. That's the hallmark of the demyelinating first attack of an optic neuritis. And usually it's an immune-mediated myelin damage, where autoantibodies they cross the blood-brain barrier and then go and attack the oligodendrocytes, and then antigen-antibody response and the damage to the oligodendrocyte. And then subsequently that causes a solitary conduction defect, which is manifest as a vision loss because it affects the optic nerves. And if any other part of the nervous system is affected, then you'll get a subsequent neurological deficit. And then once you then a remyelination, a reparative process takes on. A remyelination is done by the oligodendrocytes with the proliferation and migration, and then a functional recovery. Sometimes, if you get a recurrent attacks, the remyelination becomes improper, and then you have a permanent loss of axons, and which can lead to a deficit, permanent deficit, a visual deficit, or a neurological deficit. Now, these are some of the typical features where young age, pain on eye movement, normal or a swollen optic disc. These are some of the things which are not characteristic of an optic neuritis because of a demyelinating disease, that is the presence of exudates, hemorrhage, or more than the minimum amount of vitreous cells. This is a marked disc edema and a mild edema there. Now, coming to an entity which is seen in children, pediatric optic neuritis. So you need to differentiate sometimes when you are in doubt. Usually it's bilateral, the pediatric, whereas adult onset is unilateral. Retrobulbar here, it's morely of papillitis or a severe optic disc swelling. Usually post-infectious, whereas in adults it's demyelinating. And in children it does not, it presages the onset of MS or a multiple sclerosis. Whereas in adults, definitely it augurs the onset of a demyelinating disease. But the differential diagnoses are here: the ischemic optic neuropathy, the Leber's disease, the stellate neuropathy, as was shown in some of the pictures there. You see this marked disc edema with subretinal exudation sometimes on a fluorescent angiography. If you see, you can see the pooling of the dye inside. This is not really an optic neuritis. And sometimes you can have a unilateral disc edema with no vision loss, where you have a papillophlebitis or an early papilledema. And these are sometimes a disc edema with no vision loss, and that's one of the differential diagnoses. And here it's a chronic papilledema, and you see the swollen optic nerve all through because of intracranial tumor there, which is causing a huge amount of a shift, midline shift, with raised intracranial tension. Now, features which are not suggestive of optic neuritis: the disc and the peripapillary hemorrhages, retinal exudates, and the macular star, which tell you that it's not really optic neuritis. And this is a picture of an ischemic optic neuropathy, where you see the nerve layer hemorrhage. And here you see the optic discs here. This is how, once the recovery is there, then you tend to see a little bit of a post-neuritic disc failure. Now, coming to the workup, what you need to do is a baseline MRI scan. Once you diagnose a case of optic neuritis, your baseline MRI scan is a must, because about 50% of the patients we do tend to have lesions on the MRI which are significant enough to tell you that they may get converted into MS over a period of time. If it shows more than 2 lesions, typical white matter lesions, we need to offer the treatment with intravenous methylprednisolone, vis-a-vis no treatment to them. And these are the ancillary tests which are not really necessary, because optic neuritis is mostly clinical diagnosis with an MRI which needs to be done in all patients. So these are some of the sequences which are required: T1, T2 weighted, post-gadolinium enhanced, fat suppressed view, flare sequences for white matter lesions, and for the optic nerve sequences, these are the haste and the rare sequences. You need to tell them to a radiologist so that he knows what to take, so that you can actually have a good understanding. Now you look at these MRI pictures here of an optic neuritis of the right eye. You can see the intracanalicular portion of the optic nerve, and then the intracranial portion of the optic nerve up to the chiasma is enhancing of a severe optic neuritis in a patient who had a unilateral optic neuritis. But there were no white matter lesions. And in another patient who had a bilateral optic neuritis, if you see this, both of the optic nerves here near the chiasma, they're enhancing here. So that's a severe kind of a bilateral optic neuritis. The same patient, if you see the oblique sagittal views, you can actually visualize the optic nerve right up to the chiasm, and you can see the enhancing lesions or the active lesions in the optic nerve. You see here and here it's normal, it's abnormal here on the other side. So, briefly about optic neuritis treatment trial, as you all know, it's a landmark trial, the first of its kind in ophthalmology as such. And then the recommendations were that it was about 457 patients, and divided into 3 groups: oral prednisolone in one group, IV prednisolone in another group, no treatment in another group. And the women were more in number, and these are all the things which I've already shown you, talked to you. The age group, all kinds of visual field defects you can get. Not only that, you should get central depression, you can also get altitudinal field defects, which are characteristic of ischemic optic neuropathy, but you can also get in optic neuritis. Sometimes even the other eye also has abnormalities, like the contrast sensitivity or the visual field abnormality in the other eye. But if you look at the 1-year study of ONTT, just to briefly recapitulate, about 93% of the patients 20/40 and better, 69% 20/20 and better. About 3% patients had worse vision, less than 20/200. And the recommendations was that the patients who were given oral steroids, they had more recurrent attacks. So oral steroids should not be ever given to patient who has an optic neuritis. That will cause more recurrent attacks, more axonal damage, and more, and they'll give us a visual deficit. So it's better to not treat them, or treat them with intravenous methylprednisolone, because intravenous methylprednisolone has a protective effect against an onset of multiple sclerosis until 2 years. So you need to, each patient you need to discuss and tell them that there's a spontaneous recovery with one attack of optic neuritis, but if you give intravenous methylprednisolone, there's a faster recovery, and it also has a protective effect in the first 2 years. That's how it is. And then these are some of the changes. I'll just show you on these are called the Dawson fingers, or the demyelinating lesions in the white matter. And the flare sequence, you see more than 2 lesions. These are the patients who are at a very high risk for developing multiple sclerosis. If you see a risk of MS was 38% in patients with no MRI lesions, but when 1 or more typical MRI, 56% is a risk on a 10-year follow-up study of the optic neuritis treatment trial group patients. So it means to say that patients who have MRI abnormalities with an optic neuritis attack, you need to really treat them. You need to think about whether you should treat them in the long term with interferon therapy, which has been recommended nowadays for high risk multiple sclerosis study group patients where you have 2 or more abnormalities on the MRI with an optic neuritis attack. They are treated with interferon beta 1A across the globe, but the treatment is pretty costly. So we need to really rationalize the treatment for our Indian population, and then accordingly you need to treat them. So what it does is the Evonex or the interferon beta 1A, it reduces the cumulative development of a clinically definite multiple sclerosis by a significant amount, by about 50% in patients in the long run. So in summary, the optic nerve is the first manifestation of a multiple sclerosis. The baseline MRI is necessary, and then at the time of first episode, 50% do have lesions in the MRI, which will tell you which way the patient is going to go in the next 10 years. So you need to watch for them and treat them accordingly, because you are the most important person in this teamwork, where a neurologist also would be involved because of other reasons. So you diagnose them first, and then you actually make a diagnosis, and then you get involved with the neurologist, and then accordingly treat them in the long run if for whatever the necessary treatments which are available of late. Just half a minute. These are some of the MRI predictors. If you have more than 2 lesions on the MRI, the volume of the lesions and the gadolinium enhancing, or the presence of a new lesion on an MRI done within 3 months. So these are the treatment protocols. The CHAMP study, which says beta interferon A, weekly injection. The early treatment studies, interferon 1A subcutaneous, and then another benefit study, beta 1B. Now these are all the injections which are given weekly once. They need to be given long term for 3 to 4 years or sometimes 5 years. Nobody knows. But the clinical studies with regards to these have shown that the effect is definitely better in the people who have been given, because the cost involved is difficult in patients who cannot really afford. Nowadays, they are treating orally also. There are studies which are being conducted to giving oral interferon drugs, but the answer is not yet out whether that needs to be done. So basically, the rationale is to immunomodulate, so that you catch them early and treat them early, so that you don't land up with a significant axon loss in your central nervous system. Thank you very much for your patient hearing.